introduction. Shall I share my screen?
Yes, madam, please.
Can you see the screen?
Yes, madam.
Okay.
Make it full screen.
Yeah.
Please go ahead.
Yeah. So, good morning, everybody. First of all, sincere thanks to Dr. Arora and the entire organizing team for inviting me today for this keynote address. I've been associated with TCS for a long time since its inception, and it is indeed great pleasure and honor to be giving this talk today. At the outset, I must confess that this talk is very simple, and I have kept and more of a teaching talk, sharing our experience in the area of primary immune regulatory disorders, the role of flow cytometry for diagnosis essentially. And within this group of disorders, I will be focusing on mainly on Alps and Alps-like disorders, because otherwise it's a huge group and difficult to cover in a short time. So for those of you who are not familiar with our institute is located on the 13th floor of KM Hospital. It's a small institute, but a very old institute established in 1957. Largely working in the area of transfusion medicine and other hematological and immunological disorders. And we started working in the area of primary immunodeficiency disorders in 2006-07. So last more than 15 years now, we have been working in this area. And I'm really happy to share that we have a center of excellence for diagnosis, research and management of primary immunodeficiency diseases, along with Wadia Children's Hospital. And this is my team. So whatever I'll be presenting today is largely their hard work. And this is Dr. Priyanka Setia. She's not doctor, she is my PhD student currently working in the area of Alps diseases. So the data that I will be presenting, and now she's in the process of compiling her data, and whatever I'll be presenting today, it's actually her hard work. So over the years now that we have seen that primary immunodeficiency disorders are not necessarily defined by infections alone. There are significant proportion of these diseases which have features of immune dysregulation, like autoimmunity, autoinflammation, lymphoproliferation, and so on. So that is the reason why in 2019, the revised classification actually changed the name of this category from primary immunodeficiency disorders to inborn errors of immunity. So all primary immunodeficiencies are actually now referred as inborn errors of immunity, just to encompass these immune dysregulatory disorders. And there are nearly 430 diseases which have been categorized into 10 different categories. And out of these 10 categories, the diseases of immune dysregulation, autoinflammatory disorders, and complement deficiency are the predominantly manifest with immune dysregulation. So in this recent review, Dr. Torgerson has actually reviewed the primary immune regulatory disorders, and whoever is interested in this review, interested in these disorders, must refer to this review. So nearly 1/3 of inborn errors of immunity predominantly manifest with regulatory disorders. So it's a significant chunk and important one, which probably we need to understand and focus. So primary immune regulatory disorders, or PIRD as they are called, are a group of disorders where clinical phenotype is mainly caused by immune-mediated pathology rather than immune deficiency, which is usually a typical presentation of primary immunodeficiencies. So primary immune regulatory disorders predominantly have clinical features of autoimmunity, hyperinflammation, and lymphoproliferation. There can be associated infections, but the predominant features are immune dysregulation. The prototype of this disorder, or one of the earlier ones which was diagnosed, is IPEX syndrome, which is immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome, or IPEX syndrome, which is a prototype of this disorder where the mutation is in the FOXP3 gene, which causes defective regulatory T cells and variety of autoimmune manifestations. So PERD as a group results from genetic defects, which can be either inherited or somatic in the genes which are involved in immune regulation. And treatment of PERD, why it is important to diagnose these PERDs are because you can have specific treatments which can be directed for specific genetic defect. And I'll be discussing about this briefly at the end of my talk. And that is the reason identifying them accurately is something which is important, not only for the management of the patient and offering him curative therapies like transplantation, but also for genetic counseling, and which is also an equally important part. So there are different PERD phenotypes that have been described. There are different phenotypes that Dr. Torgerson article describes, that is T-regopathies, which I have already talked to you about, which is an IPEX syndrome or IPEX-like syndrome where you have deficiency of regulatory T cells. Then autoinflammatory syndrome, it's a huge category, and example of this is TRAPS, and multiple autoinflammatory diseases have been described till date. Then you have hyperinflammatory disorders. A prototype of this is HLH or hemophagocytic lymphohistiocytosis, and there are a variety of genetic defects which can cause hemophagocytic lymphohistiocytosis. Then complement deficiencies which result in impaired debris clearance and autoimmune manifestations. There are certain rheumatological clinical manifestations which happen with monogenic diseases, and some monogenic defects have been identified leading to rheumatological diseases. Then you have some diseases which predispose to hematological malignancies or inflammatory bowel disease, especially infant onset IBDs. Underlying primary immunodeficiency or IEI needs to be identified. What I will be focusing in next 20 minutes or so is essentially non-malignant lymphoproliferation and the underlying IEIs that result in non-malignant lymphoproliferation and autoimmunity. So there are two categories, Alps and Alps-like diseases. I will be sharing with you some of our experiences in these diseases in terms of evaluation using largely flow cytometry-based assays. So first is autoimmune lymphoproliferative syndrome. Autoimmune lymphoproliferative syndromes has been described for quite some time now and extensively evaluated. It is a primary immune regulatory disorder which is characterized by chronic and benign lymphoproliferation. This lymphoproliferation is usually waxing and waning. Usually patients start manifesting after the first year of life. They usually have autoimmune clinical manifestations, especially autoimmune cytopenias, either thrombocytopenia, AIHA, or Evans syndrome, which are the most common autoimmune manifestations seen in these patients. They also can have increased risk of lymphoma. So what they have is they have the defect in the FAST-mediated apoptotic pathway. So whenever you have an infection, there is a massive proliferation of specific lymphocytes, and these lymphocytes, after the infection is cleared, need to come back to the need to undergo apoptosis in terms of controlling the immune response. And as a part of down regulation of this immune response, activated B and T lymphocytes upregulate their FAST expression, and activated T lymphocytes upregulate their FAST ligand. And this FAST and FAST ligand interaction leads to recruitment of different downstream pathways like FADD, activation of caspases, and then cytochrome C activation, which leads to actual apoptosis. So this is this extrinsic intrinsic pathway of apoptosis, which is defective in patients with autoimmune lymphoproliferative syndromes or Alps. And the defects that have been identified are in the genes that are involved in this pathway, which include FAST gene, FAST ligand gene, FADD, caspase 10, and caspase 8. So you have, these are the genes which have been identified, which can lead to autoimmune lymphoproliferative syndrome. The majority of the patients have, nearly 75% of the patients have a FAST gene defect, which can be either inherited defect or a germinal defect, or it can be a somatic or an acquired defect, which is seen is almost 50% of the cases. So the key laboratory findings in patients with autoimmune lymphoproliferative syndrome include elevation of double negative T cells, and till date it was considered that double negative T cells are elevated, are considered as hallmark for Alps. Usually these double negative T cells are TCR alpha beta positive and 4N8 double negative. If they are more than 1.5% of the total lymphocytes or more than 2.5% of the total T lymphocytes, they are considered as abnormally elevated. Along with that, they have a defective fast mediated apoptosis, which can be, so there is an assay which can measure the fast mediated apoptosis, and these lymphocytes are resistant to this fast mediated apoptosis. Apart from that, there are certain biomarkers which have been described, like measuring serum fast ligand levels, vitamin B12 levels, IL-10 and IL-18, which are general markers which are elevated in autoimmune disorders. So what has been shown is that if you have elevated double negative T cells along with high IL-10, IL-18, fast ligand levels of vitamin B12, together they can predict fast gene defect and not the other genes in Alps, but to the almost as accurately as around 85 to 97%. So these biomarkers, along with the double negative T cells, all are very useful in diagnosis of these disorders. Apart from that, there are certain important laboratory findings that you see in Alps, which include hypergammaglobulinemia. There are different autoantibodies, as I've described, can be seen in these patients, and typical histopathological findings where you have paracortical expansion due to infiltration by polyclonal TCR alpha beta positive double negative T cells, accompanied by follicular hyperplasia and polyclonal plasmacytosis. So till recently, it was considered that double negative T cells are the hallmark of Alps, and these are really interesting cells. Right? They were first described, though the disease Alps clinical syndrome was described by Canal and Smith way back in 1967. The elevated double negative T cells were described in 1992. There has been extensive studies on the origin of these double negative T cells and their role in development of lymphoproliferation and autoimmunity. However, there are many questions. So we really don't know whether these double negative T cells are the ones which are generated early in the developmental process of T cells, or they are the late either CD4 or CD8 positive T cells which lose their CD4 or CD8 markers, and whether they are these late differentiated cells leading to double negative phenotype. So though this question remains unanswered, there is one important article that has been recently published in 2021, which clearly shows that these double negative T cell populations is not a uniform population. Within these double negative population, then you have different types of cells. At least they have identified two types of double negative T cells. One is fast controlled double negative T cells, and then you have controlled double negative T cells, which are typically seen in healthy controls. So this fast controlled double negative T cells which in patients with Alps are obviously resistant to fast because of the defect in the fast mediated apoptosis, and they are the ones which get expanded and they have a distinct phenotype. So with this background now, I'll tell you what has been our experience in from our study in related to Alps. So last many years, we have been evaluated patients with Alps. We realized that double negative T cells are not really the hallmark of Alps, but they are elevated in variety of other diseases. So we actually decided to take up this study, and Dr. Priyanka Setia is working as a PhD topic is basically to understand the spectrum of autoimmune lymphoproliferative disorders and the double negative T cells that are seen in patients with Alps. So characterize these double negative T cells using variety of markers and to see whether we can differentiate Alps from other Alps-like diseases. So this is just a part of our PhD topic, which I'll be sharing some of our experiences with you. So what we decided was evaluate patients who are predominantly manifested with autoimmunity and lymphoproliferation or multiple autoimmune phenomenon. So all these patients were then systematically evaluated by looking at lymphocyte subset analysis, double negative T cell characterization, looking at immunoglobulin levels and their extended T and B cell immunophenotyping. Along with that, we also looked at the biomarkers which have been described as important ones for diagnosis of Alps. Then molecular confirmation was done with NGS analysis, and beyond NGS analysis, whatever defect was identified, then we tried to then functionally validate either by looking at specific protein expression, or if there are some downstream functional assays, we especially like apoptosis assay that we have tried to do in these patients. So lymphocyte subset, so initial screening, we have now developed a panel of 13 antibody, which is a modification of Euroflow panel, where we have added HLA-DR, and this HLA-DR actually has helped us significantly, especially in characterizing or predicting whether this patient is likely to have an Alps-related double negative T cell. So it's a 13 antibody panel, which can give you a comprehensive overview, initial overview of the different subsets in the peripheral blood. If there is any abnormality in these initial evaluation, we do an extended T cell phenotype. Of course, some of these subsets are picked up in our initial screening panel, like naive T cell, central memory, effector memory, and activated T cells are picked up by our initial screening panel itself. But double negative T cell, regulatory T cell, follicular helper T cell phenotyping needs special panels, and those patients, all these patients were evaluated and looked at these populations. Then we also looked at extended B cell phenotyping, so looking at memory B cells, class switch memory B cells, especially plasmablast, and CD21 low B cells, beyond looking at B cell numbers. Then coming to characterization of double negative T cells, what we have done is looked at TCR, CD3 positive, TCR alpha beta positive, 4 and 8 double negative population. And this 4 and 8 double negative population is then we have looked at the variety of markers, which included CD27, 28, 22, B220, 57, and HLA-DR to look whether there are any phenotypic differences between the normal double negative T cells versus the Alps double negative T cells. Patients with defect in the fast mediated apoptotic pathways were functionally validated by looking at apoptosis assay. Then, based on these initial immunological evaluation, there are 3 distinct patterns emerge. One is where you have elevated double negative T cells with normal or elevated immunoglobulin levels and elevated biomarkers. Then These are the group of patients where there is a strong suggestion of underlying Alps. There are patients where you have double negative elevated, but you have normal to low immunoglobulin levels and additional T and B cell abnormalities, and they are the ones which probably do not have Alps, but they have some other Alps-like genetic defects, which were then confirmed by NGS analysis. So over last 3 years, we have evaluated nearly 161 patients. So there is a lot of referrals with which are referred for Alps, out of which 40 patients presented with lymphadenopathy, splenomegaly, hepatosplenomegaly without autoimmune cytopenias, and clinically strongly suspected to have Alps or Alps-like disorders, which were then systematically evaluated further. So out of these, we identify or molecularly confirmed 8 patients with Alps or autoimmune lymphoproliferative syndromes. And to our surprise, we identified only 1 FAS gene mutation, and remaining 7 were other mutations related in, or mutations in other genes in FAS apoptotic pathway, which included interesting FAS ligand gene mutations, 3 cases, FADD 2 patients, caspase 8 and caspase 10. So we had actually, rather than having predominantly FAS defect, we actually had variety of defects which were seen in patients with Alps. What was striking was majority of them, all of them in fact, had lymphoproliferation in the form of lymphadenopathy or splenomegaly and autoimmune cytopenias. Infections were relatively mild. The key abnormal laboratory features included elevated lymphocyte count, which was seen in around 50% of the cases. B cell phenotype and initial lymphocyte counts were variable and influenced by the underlying or immunosuppressive therapy that the patients were taking. What was important is immunoglobulins were normal or elevated in majority of the patients. Double negative T cells, of course, a significant proportion had elevated double negative T cells. But some of them, only 2 patients had actually normal double negative T cells, or they were in fact quite low. And this may be because of the immunosuppressive therapies that the patients were on. And they had characteristic features of double negative T cells. I'll come to that in my summary slide. Then what of the biomarkers, what we evaluated, we found that FAS ligand, serum FAS ligand levels were significantly predicted underlying FAS or other gene defect. FAS ligand gene obviously had absent or significantly low serum FAS ligand levels. And 1 patient or 2 patients had normal FAS ligand levels. And again, this may be because of the immunosuppressive that these patients were taking. Surprisingly, other biomarkers really did not help us. Again, vitamin B12, which was described nearly elevated in more than 80% of the cases, we got elevated only in 50% of the cases. So what we realize that when you have a setting of lymphoproliferation, hepatosplenomegaly, autoimmune cytopenias, and elevated double negative T cells, it is not only Alps that we identified. There are many Alps-like diseases that we identified, which included APDS, CTLA4, LRBA deficiency, and one case of this RALD, STAT3 gain of function, and X-Men disease. So this clinical phenotype not only has underlying Alps, but Alps-like diseases. And out of these 18 patients, majority of the patients were of these 3 categories, which is LRBA deficiency, CTLA4 deficiency, and activated PI3 kinase delta syndrome. So LRBA deficiency, briefly, LRBA is a huge protein with multiple functional epitopes, but one of the important function of these LRBA protein is recycling of CTLA4 molecule. And this CTLA4, so if whenever you have LRBA protein deficiency, you have a deficiency of CTLA4. And CTLA4 is an important immune checkpoint protein, which is expressed by activated T cell, and actually after ligation inhibits proliferation, and that's why it is extremely important, or an important protein for controlling immune responses. So whenever you have, and CTLA4 is an deficiency which is inherited as an autosomal dominant form, and it is also called as a CHI syndrome. So apart from that, we also had two cases of PI3 kinase delta syndrome, or APDS. And again, this PI3 kinase is an extremely important pathway involved in a range of cellular processes like proliferation, growth, and differentiation, and motility and survival. And what is interesting is you have a gain of function mutation, not a loss of function, but gain of function mutation in a heterozygous form, which leads to hyperactivation of mTOR pathway, and which leads to cell proliferation advantage and cell survival and autoimmunity. So this is in brief the clinical features seen in these three different categories of Alps-like syndrome. Majority of these patients presented with lymphadenopathy and autoimmune manifestations. But apart from that, what is striking is they also have significant proportion of these cases have infections as a predominant clinical manifestations. And why they have infections, that they have other T and B cell abnormalities which can be picked up by extended phenotyping. They have significant proportion have lymphopenia and hypogammaglobulinemia, and they also have low naive TH cells, low memory B cells, as well as class switch memory B cells, hypogammaglobulinemia, and some of them also have expansion of CD21 low B cells, especially those with manifesting with autoimmunity. So this is in brief. So we characterize the double negative T cells not only in Alps but Alps-like diseases, and this is something interesting that we identified, that Alps-like patients with Alps have a typical features or immunophenotypic characteristics which are distinct from the Alps or Alps-like diseases, and as well as the double negative T cells which are identified in controls. And these cells are 27 positive, 28 positive, HLA-DR positive, CD45RA positive, CD57 positive, KLRG1 negative, and 220 positive. And the recent studies have shown that these are, there is a definite expansion of, so this is a kind of phenotype that you see in fast controlled double negative T cells. And these fast controlled double negative T cells actually secrete IL-10. They have a high proliferative capacity and they are resistant to fast. So that is the reason why there is expansion of these cells in Alps. Whereas in LRBA, CTLA4 and APDS, these immunophenotypic characteristics are not seen. However, and they are probably more similar to control, though there are subtle differences. We are currently analyzing them. And once we've analyzed this data, we'll have a clearer picture as how the double negative T cells in these other Alps-like diseases are different from Alps. So what has been recommended now that when you are evaluating in a setting, clinical setting of autoimmunity and lymph proliferation, not only that you look at CBC, immunoglobulin levels and biomarkers and double negative T cells, but you need to do an extended immunophenotyping for T cells and B cell subsets. And maybe characterizing the double negative T cells further to understand whether what is the underlying genetic defect. So this was the kind of immunophenotypic characteristics of Alps and Alps-like disorders that we evaluated at our institute. Why it is important to diagnose these diseases is that otherwise autoimmune diseases and lymphoproliferation is empirically treated either with steroids and then different second line therapies. But once you have identified these genetic defects, you can have biologic modifiers which can be specifically given. Like if you have a CTLA4 deficiency, you can treat them with abatacept, which actually binds to this CD80 and 86 and functions as CTLA4, and the clinical symptoms are significantly improved. And abatacept is this antibody which is available in India, and there is a remarkable clinical improvement which is seen with this specific therapy. Similarly, you can have specific PI3 kinase inhibitors, you can have mTOR inhibitors, especially sirolimus, and this mTORopathies, especially PI3 kinase or APDS syndromes, respond very well to mTOR-directed therapies. And if you have abnormalities in JAK-STAT pathway, you can actually use JAK-STAT inhibitors with significant clinical improvement. So this is just one example of patient where we had a CTLA4 deficiency. He had a reduced expression of CTLA4. I understand this graph because the gated lymphocyte or gated, has to be seen on the regulatory T cells, and the number of regulatory T cells are really low. But this patient was treated with abatacept therapy, and you can see that this restored the CTLA4 expression in this patient along with clinical improvement. So I think that was my last slide. I'd like to summarize the lessons that we've learned from this exercise of looking at or trying to evaluate patients with benign lymphoproliferation, with or without autoimmunity, which always remains a challenge and usually often empirically treated. What we found that significant proportion, so out of 50, nearly 50% of them, more than 50% of them had an underlying inborn error of immunity. And what we found that though we think of Alps more often when we find lymphoproliferation and autoimmunity, Alps-like disorder are much more common than Alps. What we also found that though elevated double negative T cells is an essential major criteria for Alps, some of the patients with Alps may not have elevated double negative T cells because patients treat, this may be because the patients treated with steroids, the steroids may have effect on the number of double negative T cells that you see. So along with double negative T cells, a combination of biomarkers can be used, and the most appropriate biomarker or sensitive biomarker that we found was fast ligand, which predicted fast defect or was found to predict, found useful to predict fast underlying fast defect. Then what we also found that elevated double negative T cells are seen in many inborn errors of immunity. Majority of them are associated with autoimmune manifestations and are not specific for Alps. If you have a facility for immunophenotypic characterization of double negative T cells, it may help to predict Alps, as the Alps DNTs or these fast control DNTs have a unique or distinct immunophenotypic characteristics. So this may, if you do it upfront, it may help to differentiate between Alps and Alps-like diseases. What is also important is looking at extended T and B cell immunophenotyping to understand subtle differences in these subtypes, which may predict an underlying genetic defect. And then these patients the molecular confirmation needs to be done by NGS. I think I will stop here. I would like to acknowledge all my lab members and of course the clinical collaborators who keep sending us very interesting cases. And these are the collaborators who have sent us these cases of Alps and Alps-like disorders, and I would really like to thank them sincerely, because without these interesting cases, we would not have been able to do this study. I think with this, I will stop here. This is a photograph of one of our Indo-US workshop that we had done it in flow cytometry. We actually have this workshop every year for diagnosis of primary immunodeficiencies, and if anybody is interested, usually it's in the month of September. You can join us for that. Yeah. Thank you. Thank you so much.
Thank you very much, Dr. Manisha, for a masterly talk on primary immune regulatory disorders. And it's surprising to know that a substantial number, at least 1/3 of the disorders are from this particular category. So very nicely done by you. And I want to ask you a few questions, which are in there's one in the question answer box by Dr. Amit Rawat. He wants to ask how many of the patients with ALPS had autoimmune hemolytic anemia. Was DCT done in these patients, in all patients?
I think majority of them, nearly 70% of them, all 100% had immune cytopenias. AIHA was seen in nearly 70% of them. So majority of them had AIHA as clinical manifestation. So AIHA, either alone or in the form of Evans syndrome, is one of the strong indicators where you should look for underlying IEIs, especially immune regulatory disorders.
So I don't see any more question in the question answer box, though there are certain comments in the chat box where people are trying to appreciate, even Amit Rawat, Krishna Murthy, Mitali, everyone. So I'm sure everyone enjoyed your talk. Thank you very much for giving your time and bringing out all this data and all these intricacies of primary immune regulatory disorder. So because of shortage of time, we'll have to stop your session. We started a bit late in the, as you know. So I'll thank you once again and thank all the audience also. And now hand over back to the organizers to carry on with the next session. Quickly, please.
Thank you. Thank you so much.
Thank you.
Thank you, Dr. Manisha. Thank you, Dr. Manisha, for this insightful talk. Now I would like to request Dr. Mitali Chatterjee to chair the session 1. Dr. Mitali completed her MBBS from Medical College, Kolkata, and obtained her MSc from Newcastle University. She also completed her PhD from Indian Institute of Chemical Biology, Kolkata. She has an immense contribution in the development of immune-based biomarkers, mainly in leishmaniasis, and their application as tools for monitoring the disease progression. Dr. Mitali, please join us.
Thank you. Thank you very much. A very good morning to all of you who are present here. And it's wonderful to be a part of the TCS annual meeting. It's rather a pity that we are having to do it virtually. We hope that by next year, we will be able to do it in person, because it's always a pleasure to share one's work face to face. So today we have a very interesting session on translation research. We have two of India's finest immunologists and translational scientists. So it is my pleasure to introduce. So today we have Dr. Dipendra Kumar Mitra, and we have Dr. Amita Agarwal, followed by a talk by a representative from BD Biosciences. So our first talk in this session on translational research. Translational research is an area where flow cytometry actually plays a very key role, because you often want to see what is happening in a real-time mode. And so Dr. Dipendra Kumar Mitra, who is the professor and head, the Department of Transplant Immunology and Immunogenetics at All India Institute, New Delhi. Welcome, Dr. Mitra. Dr. Mitra has very diverse interests. They range from looking at chronic intracellular infections, which includes tuberculosis, leishmaniasis, sarcoidosis, leprosy, as also co-infections, HIV with tuberculosis. It's very important. It's, I think, a part where cytometry plays a very major role, because you're wanting to look at the effect that the intracellular parasite or bacteria or microorganism has. He also has an interest in rheumatoid arthritis and study of immune transplantation. He is currently working on TB vaccine trials, and his lab offers diagnostic services for patients with leukemia and immune deficiency disorders. So I'll hand over to Dr. Mitra, who will take us through this journey regarding pulmonary sarcoidosis, where he will be talking about how inhibition of OX40 can rescue lung infiltrating Treg cells, and importantly, what is the potential therapeutic implication of his studies. So you have half an hour, Dr. Mitra, to tell us about your work. I know half an hour is not adequate, but for the sake of time, we'll request you to tell us